Hello, ladies and gentlemen. Divine, the pharmacist, here with a difference. It's been a long time since you saw me on my channel. But you know, you don't think that, of course, we're doing. And it's been a really rough year and a busy year. So we couldn't just close the year without giving you a bonus video for this 2020. So today I'm going to be talking to you about fluoroquinolones. Fluoroquinolones, we'll talk about them in a way that is going to be very easier for you to understand them and how you can apply them. So it's going to be looking at simply the mechanism of action of fluoroquinolones. We'll talk about the classification of fluoroquinolones, and we'll talk about the clinical application and also the most common adverse effects. So ladies and gentlemen, what are fluoroquinolones? So these are a group of antibiotics that usually work, of course, on the DNA level. They inhibit DNA synthesis of the microorganisms, the pathogens, or susceptible organisms. So, fluoroquinolones, the way they work is that, what I want you to understand clinically, basically here, important is that we have a DNA. You know, usually that the DNA, of course, is a double-stranded DNA. Okay, so that's the DNA, of course, put like this. Okay, so, you know, the DNA is important for the, of course, everything to survive. Of course, microorganisms, of course, they require DNA replication for them to survive, or for also proliferation, and that require DNA. So what happens basically here is that in the organisms, there are special enzyme that we call the helicase enzyme. So this helicase enzyme, what it does basically is that it actually unwinds the DNA. It opens up the double-stranded DNA so that transcription can occur. So this is, of course, how it happens. So it has to open the double-stranded DNA so that transcription can occur. So that enzyme is what we call the helicase enzyme. Now, this what happens basically that when the DNA itself is being unwound, this part here becomes super tight and strong. When it's very tight and strong, transcription may not continue to occur. So as a result, there are also other enzymes, special enzymes, that are involved in making sure that the DNA doesn't become super tight so that transcription may occur. So these enzymes, of course, are two of what we call topoisomerase. Topoisomerase type 2 and type 4. So these type 2 and type 4 are very important topoisomerases that are involved in the softening of the DNA as it's being unwound so that transcription may continue to occur. So this class of drugs are the fluoroquinolones. The fluoroquinolones, the way they work is that they simply inhibit these two enzymes. So if these two enzymes are inhibited or are they blocked, that means that when transcription is being occur, when it's happening, what happens that it's going to be so tight here so that transcription won't occur. So if we block these enzymes which function in a way that they they soften the DNA so that transcription may occur, that means that the transcription process will be cut short or be held down. That's how fluoroquinolones work. They simply block these two enzymes. Then the organism, of course, will die. That they have what called bactericidal effects. So because they cut down or stop the DNA production. That's how they work. I hope that is very simple and clear on the mechanism of action of fluoroquinolones. Let's talk about now classification. Fluoroquinolones, they are classified, of course, in 4 important generations. They are classified in generations. Now, I'm going to show you so that you see how they are classified, and how they're classified is very important clinically and how you apply them. So we have got what we call the first generation. The first generation, of course, here, these guys, of course, they've got narrower activity. They are narrow activity, they are confined much more to the kidneys and also to the abdomen. So they are used clinically, of course, use them much more to the the UTI, of course, cystitis in that case category, as well as also some dysentery or other diarrhea that caused by dysentery, and also protozoa infections. That's what you use them for. And the example of the first generation, of course, these are called quinolones. They are called quinolones. When you say fluoroquinolones, there's this addition of halide metals and making them, of course, more lipophilic and to have extended spectrum of activity. But with the first generation, these are called quinolone. An example of this first generation is the nalidixic acid. So nalidixic acid, of course, comes from what we call the first generation quinolone. And this one, of course, is confined to that narrower, as I said, in activity. Okay, we have got, of course, the second generation. Of course, here we have, of course, the common drug that, of course, you hear people talk about, the common one. Say this drug, you know, here and there. We have got example, of course, is ciprofloxacin. So ciprofloxacin, ofloxacin, and of course norfloxacin. These, of course, are what we call the second generation fluoroquinolones. Okay, we got, of course, the third generation. So third generation fluoroquinolone, of course, we've got levofloxacin. So levofloxacin is our third generation fluoroquinolone. We have, of course, the fourth generation here. We have, of course, here moxifloxacin. We have also gatifloxacin. Okay, so these, of course, are the fourth generation fluoroquinolones. Now, we're going to look about how you now clinically, how are they applied. So this simply, I've talked to you that fluoroquinolones are classified in clinically or important 4 generations. The first one, of course, is what's called the first generation, second generation, third generation, and the fourth generation. I've explained saying that in the first generation, of course, we have the drugs like nalidixic acid. In the second, we have, of course, ciprofloxacin. We have got ofloxacin. We've got norfloxacin. I've explained that in the third generation, we have levofloxacin. And in the fourth generation, we have got what we call moxifloxacin as well as gatifloxacin. So, ladies and gentlemen, this classification is very important clinically because this determines, of course, there is, of course, additional of activity and coverage as you move from first generation to fourth generation of the fluoroquinolones. That's very important. Now I'm going to the next part. We've talked about, of course, the mechanism of action. I've classified them, of course, in the from first to third to fourth generation. Now we talk about what we call clinical application now. So here's the thing now. How do you apply them clinically now? Okay. So this is where we're going to have the most amazing. I want you to understand this part. It's very important. So the first part, of course, is the first generation. These, as I earlier said, they are more confined to kidneys as well as also abdomen. So they are narrower activities. They don't cover much most what we call organisms. So they are simply more good to treat simply lower urinary tract infections. So urinary tract UTIs that are on lower cystitis, this drug, of course, you can use nalidixic acid. Want to treat, of course, some kind of diarrhea that, of course, can do what with protozoa infections, like dysentery and other kind of protozoa. Can work. These guys can work. They're going to do the good job there. But they are not good, of course, for systemic infections because they have little of the drug in the system. That's why these guys are not used to treat systemic infections. That's very important. So the narrower activity covers, of course, E. coli. It covers E. coli, this class group, and also antiprotozoa activity. So less reliable to treat some confined or tissue infections because of its reduced in what we call tissue penetration. Hope that is clear. Going to the second generation, ciprofloxacin and ofloxacin, these guys, of course, have got additional activity in when it comes to the first generation. They have got good activity against a number of gram-negative organisms. So this class of drugs covers a number of gram-negative bacilli, gram-positive organisms. They've got broader spectrum of activity and they are more reliable to treat certain number of infections. In the case of ciprofloxacin, of course, it is used even actually to cover Pseudomonas infection. So Pseudomonas ciprofloxacin, ladies and gentlemen, actually has got the strongest activity against Pseudomonas of all the fluoroquinolones. Ciprobid is the strongest and superior against Pseudomonas activity. So this category of drugs, they are more inclined to gram-negative. So they have got more activity or enhanced activity toward gram-negative bacilli organisms. Because the reason is simple, is because the two enzymes I earlier mentioned, topoisomerase type 2 and type 4, The type 2 one is more confined, or rather more regulate transcriptions in most of the gram-negative bacilli, but type 4 is found in gram-positive, so it's more function in gram-positive bacilli, gram-positive organisms. But type 2 is more commonly found in the gram-negative. It's a co-regulator of transcription in the gram-negative bacilli organisms. That's why you find that this class of drugs here, because of their affinity towards the DNA gyrase, that's why they have got enhanced activity towards the gram-negatives. That's why you see these drugs very superior. You can use ciprofloxacin, of course, to treat bone, because these guys, of course, are fluorinated for bone infections, of septic arthritis. You can use to treat what we call, even actually for prophylaxis of infection. Maybe those who have undergone hip replacement surgery or knee replacement surgery, you can put them on such category of drugs. Ciprofloxacin, of course, can be also used to eradicate Pseudomonas infection, of course, in case of cystic fibrosis, as well bronchoectasis. You can use ciprofloxacin, of course, is good for application. You can also use ciprofloxacin to treat pelvic inflammatory diseases in women, of course. And number, of course, initially ciprobid was used to treat gonorrhea, but it developed resistance, so it's not a good drug to treat for gonorrhea. Ciprofloxacin is not a good choice for that. But it has got coverage for Staph aureus. In a case somebody comes in with cellulitis from the community, of course, with discharge, ciprofloxacin has got good coverage for community-acquired MESA, so you can use that to treat that. Okay, next part, of course, is the third generation, the levofloxacin. Levofloxacin, guys, in addition to what ciprobid can do, levo has got additional activity. Levo also is able to cover atypicals. That's why levofloxacin, of course, here is able to do what ciprobid can do. But remember, as I said, it's not very much potent to Pseudomonas as ciprobid. It is actually used to treat Pseudomonas. You can use the levo to treat Pseudomonas infections very well. It's good, but it's not superior to cipro. Levo has got good lung penetration. Ciprobid is good for blood systemic infections. Very strong and reliable for systemic infections, because ciprobid is well distributed systemically. But levofloxacin also has got enhanced activity toward the pulmonary system. It's got a very good lung penetration. That's why it's more used to treat in pneumonia cases, to treat for what we call bronchoectasis and different kind of infections that, of course, can affect the lungs. So levofloxacin, of course, as I said, that it covers also atypicals, meaning that if you are treating somebody, of course, let's say with pneumonia, with this, you think of atypicals, you don't have to worry about covering for atypicals when you're using levofloxacin, because the levofloxacin is able to cover atypicals very well, and it covers most of the gram-positives and gram-negatives very well. It's a good drug, and if in case where you're not sure what you are dealing with in the patient, levofloxacin is a good, because it's able to treat a number of organisms. So these guys, of course, they are applied in many applications. In Zambia, we use them, of course, as a MDR-TB. You can treat, of course, levo using pneumonia. Some STIs can be treated using levofloxacin, because it covers, of course, gonorrhea excellently. For gonorrhea, this is excellent, plus chlamydia. So you don't have to worry about adding chlamydia drug if you're using levo for treatment of an STI in your area. So it's able to cover everything. It covers, and let's just add maybe for anaerobe drug, but it covers gonorrhea excellently for gonorrhea reliable activity, for also treating for atypicals like chlamydia, trachomatis, chlamydia cysticercosis, and species, so different species of chlamydia, mycoplasma. All of them, they are covered with this drug. Okay, next category, of course, is the fourth generation, which are called the moxifloxacin as well as the gatifloxacin. This group of drug, ladies and gentlemen, as you can notice that as we move from the first to fourth, there's addition of activity. In the fourth generation, these guys are able to cover also anaerobes. These drugs have got they've got good anaerobic activity. You can use moxifloxacin to treat an anaerobic infection, an anaerobe. So, of course, you talk about bacterial fragilis activity, of course, is excellent. Gardnerella vaginalis, excellent activity. You talk about Peptostreptococcus, excellent. What you call actinomyces that are found in the mouth, it covers very well. So this category of drugs, they're able to cover for anaerobes very well. So you can apply these drugs, of course. This can, in case of you're thinking of polymicrobial infections, but you don't know what is causing that, you can go with this category of drugs. They're also used, of course, as well in the MDR-TB. You can use this category of drugs. You can use this drug to treat a number of what you call gram-positive infections or sepsis, and also different gram-negative organisms. But let me say this, moxifloxacin is not that good for gram-negative, especially Pseudomonas activity, of course, is unreliable. So clinically, we don't use moxifloxacin to treat Pseudomonas infections. That's very important to understand. That point is very important. But understand that these guys, they cover anaerobes very well. That's under the clinical application of fluoroquinolones. So let's go to the last part, last portion. We'll talk about the most common important side effects. Here, of course, I'll talk about the major, what you look out. You know, with this category of drugs, these drugs have got some side effects. One of them includes, your worry with these adverse effects, ladies and gentlemen, is that they can cause tendonitis or tendon rupture. So these guys are prone to cause tendonitis because most of them, of course, they're very concentrated in the bone and also in the bone joints. So tissues, they're able to actually cause tendonitis. It's prone with that. The other thing that you worry with this class of drug, of course, also is what we call pseudomembranous colitis, especially with what we call this class second generation, when fluoroquinolones, they are like to cause pseudomembranous colitis. Of course, this is of course a diarrhea kind of disease where there's overgrowth of some gram-positive in the gut and bring about imbalances that bring about diarrhea. So this class of drugs, they cause that as well. Apart from that, of course, what you worry more, again, with these drugs, people with heart failure, is that they also cause QT prolongation. So this is a phase where the prolongs the stage where the heart is in relaxation phase. So you can cause what you call bradyarrhythmias in most people. So that's why you have to watch out for that. So people who have got heart failure, you have to be cautious using these drugs. So the worst one, of course, is this generation. The fourth one, they are more culprit at causing QT prolongation. So the MOX one is more worst side on the bad side compared to this other generation. These are friendly when it comes to heart QT prolongation. So that's basically you have to understand about this class of drugs, and they also cause seizures. Okay, they cause seizures and little light headaches. So you just get somebody, of course, who have got a history of seizure, and then they're on these drugs and wondering why they start having seizures again. You can just start to see that the possible causing that, of course, is that these drugs, of course, they also cause seizure. So this is what I had for you as I close 2020. Ladies and gentlemen, it's been a great year, and thank you for your support. And I've just last to say is that if you're an intern pharmacist in Zambia and you want guidance on how to go about with the exams preparation, what to start, what to know, you can simply inbox me and we can make arrangements on how you can actually get to arrange something for you, and you can just inbox us. So this is what we had, and God bless you. And today I was with Pharmacist Abraham, and it's good to be here again. Happy festive season. God bless you.